Oh, no. Hi, Dr. Sabea. Hey, Dr. Sabea.
Hello, how are you?
Yeah, good, good. I made a mistake with the link. So let's wait about 10 minutes, okay?
Sure.
Because I'm going around now and saying, whoa, I got let me give you the right link, okay? So I'll be back in about 10 minutes, okay?
That's good. Thank you.
Hi, Dr. Sabea. Well, we got a couple minutes.
Sure.
We got a couple minutes, Doc.
Yeah, I will.
So how have you been?
تحكي معه.
Hey, Czar, I communicated with you this morning. Right, Tay, on Facebook.
Hello, John.
Hey, how you doing?
Yeah, I'm fine.
Where,
are you?
where are you? Indonesia?
No, I'm from Myanmar, Yangon.
Oh, Myanmar. I'm Sue is there.
Yeah.
I know Sue.
She is from another hospital.
Oh, she's not there at the same hospital as you?
Yeah. Thank you so much for your arranging and for support. You're so great.
Yeah. It's getting better. It's getting better because neurosurgeons are starting to understand it and are using it and trying it. You know, before it was difficult to get them to try it.
Yes.
You know, because they're busy. They're busy. They don't have time to stop and learn the program.
During this day, we have opportunities to get the lecture from the China.
Yeah. You can come in any webcast we have, and you can participate and talk. Did you see Dr. Goel's lecture this morning?
Yes.
Yeah, he's great. I mean, he's a good
Yes.
teacher, really good teacher.
Yes.
And Dr. Sabea is too. Okay, we're going to start now. And this, oh, second. Okay, you ready, Dr. Sabea? You got to unmute you there. Okay, ready? 10, 9. You ready, Dr. Sabea?
I'm ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. It's Dr. John Bennett broadcasting from Miami Beach. We have the honor today of broadcasting grand rounds from Jordan with Dr. Ibrahim Sabaya, a neurosurgeon educator that's been doing these, not webcasts, but doing educational seminars for 27 years. And luckily, we got him to try new technology to reach more followers. And rather than stumble through all the introductions, why don't we just go straight away to the presentation, Dr. Sabea, and it's all yours, and thank you.
Thank you very much indeed. I would say good evening, good morning, wherever you are. Greetings from Jordan, where I'm stationed now. And this is the Farah Medical Campus where I work in Amman, Jordan. As I always start by stating what is the presentation about today. It's pineal locus tumors. And as usual, we'll go through clinical, radiological, operative, and pathological correlation. Before we do that, I'll just present to you some of the features of my beautiful country, Jordan. This is the city of Jarash, the only intact Roman city outside Italy, outside Rome. So it is really well intact city from the times of Roman, 7,500 BC. And this is the main center of the old Roman city. This is the picture at night where people visit. And this is the circle there with the columns. As you can see. The main street in the old city of Jarash, the Roman city. This is a time of spring. And this is the main auditorium where festivals and ceremonies would take place. And in Jerash, since 1980, we have the Jerash Festival. So about 40 years now, with this festival going on, attracting hundreds of thousands of people from the Arab world and surrounding countries, because it's really unique and special. All sorts of entertainers, singers, musicals are performed here. So imagine sitting among the ancient ruins of Jerash, listening to Bolshoi opera, listening to opera singing, etc. So it's a beautiful city of Jerash. So Jerash Festival. I don't know whether we have it this year or not because of the coronavirus, because it's usually July, August. Hopefully it will be open by then. So back to our presentation, pineal locus tumors. And I have to go through the anatomy of pineal gland. I thought, and I always still thinking, that people do not understand well, especially the residents, the pineal gland physiology and anatomy. Pineal gland, as you can see, this is a small gland sitting at the back of the brainstem. This is the superior and inferior colliculus on one side, superior colliculus, inferior colliculus on one side, pulvinar of thalamus, and this is the back of the third ventricle. So here you are sitting there, and this is pulvinar, this is the pineal gland, the superior colliculus. And if you go above it, then you can see the whole of the cavity of the third ventricle with the massa intermedia there. Why is it called pineal? Because it looks like pine tree. So that's the name where it came from. So that's the pineal gland. As such, the superior colliculi here and the pineal gland there. Again, here, if you are looking from behind, from posterior view, you can see the pineal there with the superior and inferior colliculi. It's a very critical area where this beautiful gland is situated. So the tent, the pulvinar of the thalamus, the parahippocampal gyrus, the temporal lobe, and there are the veins, the vein of Galen, and so on, giving the Vermian vein. Closer look at how it looks from underneath the tentorium, and here is the parahippocampal gyrus. So this is the gland, superior colliculus, inferior colliculus. Here is the sulcus, the mesencephalic cerebellar sulcus, and in here comes the fourth nerve from the back of the midbrain. Again, you can see this little gland sitting, and this is the cavity of the third ventricle. Same thing in here. Why am I showing this? Because we will see this through the video. So if we don't understand anatomy, we will miss the pictures that we are going to see, still pictures and the video running. So this is the pineal gland looking like a pine tree. And this is the so-called the crus. There is one crus on one side, another crus on the other side. Sagittal view. This is the corpus callosum, the splenium, and you can see that we are here. Again, cut through the midline. Then you can see the quadrigeminal plate of the midbrain, the tectum of the midbrain, and here is the posterior commissure. And then we have the pineal gland, and there is a recess that's going into the body of the pineal gland, and above it is the appendicular commissure. So anterior commissure is here at the upper end of the lamina terminalis, and posterior commissure is here, appendicular commissure is here. Same thing here, tectal plate, superior inferior colliculus, posterior commissure, and that's the gland, and this is the splenium. And here, through this small space, comes the internal cerebral veins to join together with the other veins, vein of Rosenthal, to form vein of Galen. Same picture, splenium of the corpus callosum, the pineal gland, the internal cerebral vein coming this way to form, with the other veins, the greater vein of Galen. Same picture, internal cerebral veins coming from the roof of the third ventricle to form. So the pineal gland is tucked here between this structure here, this structure here, and this structure here. Splenium, cerebral veins, joined with other veins to form vein of Galen, which will form here the straight sinus. Closer look again. This is the posterior commissure, this is the pineal gland, and this is the pineal recess, and this is the hypennular commissure. One has to be familiar with this anatomy if one wants to operate in this area. So, what is the pineal gland? What's the physiology? What's the function of the pineal? It's an endocrine gland, and it secretes melatonin, which regulates our sleep. So melatonin is involved in the sleep-wake cycle that we experience. The melatonin is secreted at night so that it will prepare us to sleep. Once the daylight comes, the secretion would decrease so that we can get up. So melatonin secretion is at night. Early morning, it decreases the secretion. So if you are traveling in an airplane, whether east or west, then you are sort of having the lights in the airplane on, and then the melatonin would think that this is still daytime, so decreased secretion. That's why you get the jet lag, because melatonin is not working. And the pineal gland shares this function with the suprachiasmatic nucleus of the hypothalamus. Both are related to this sleep-wake cycle. So melatonin is our sleep hormone. And as I said, whether you receive a light through daylight, or your eyes are closed, or there is dim light, there is closed light, black light, then the communication between the anterior commissure and the posterior commissure and the pineal gland would cause the secretion of melatonin, as I said, at night. So this is the clock. At 6 a.m., when we want to wake up, the melatonin secretion stops so that we'll feel that we are energetic and get up, while starting sort of 6 p.m. and beyond that, 9, 10, 11, melatonin secretion starts, and then you feel the desire to sleep. As I said, this is shared with the suprachiasmatic nucleus of the hypothalamus. With the connection between suprachiasmatic nucleus, the mammillary body goes to the anterior commissure, and then from the anterior commissure goes through the fornix to the area of the pineal gland. Again, here, this tentorium anatomy is important because the pineal gland is resting here, so we have to understand this anatomy, and therefore we have to understand the veins that are there. And I've always been struck that most of the neurosurgical residents, they have no idea about the venous anatomy, as if it does not exist, as if the veins are not important. It is very important, especially in this area. So this is the superior sagittal sinus taking all these superficial veins, the sort of cortical superficial venous drainage going to the superior sagittal sinus. And then we have the inferior sagittal sinus in the inferior edge of the tentorium. And here, the thalamostriate vein joins with the anterior septal vein to form the internal cerebral vein. And the internal cerebral vein will be joined by vein of Rosenthal to form the vein of Galen. Here, the superficial middle cerebral vein would drain into sphenoparietal sinus and then into the cavernous sinus. So it's important anatomy, and this can be demonstrated in this venogram. This is one of my patients, and you can see the anatomy that we just described, the internal cerebral veins and the venous drainage into the cavernous sinus, inferior petrosal and superior petrosal sinus. This is vein of Labey. If you look at the vein of Rosenthal, which is an important component of forming the vein of Galen, then it will start here from the anterior cerebral vein, joined with the deep middle cerebral vein to form this trunk here. So anterior cerebral vein, middle cerebral vein, joined by this peduncular vein, going around the brainstem, receiving these veins from the hippocampus and parahippocampus, receiving also veins from the medial temporal area, and then joined by the internal occipital vein to form, as I said, with the internal cerebral vein and vein of Galen. This is a beautiful demonstration in Yazarjil book, and I will refer to this point in a big way. It's no good that people read from little handbooks of neurosurgery thinking that this is what they need to learn. I mean, every neurosurgical resident, every neurosurgeon must have this image that I'm showing into his mind, because this is a 3D kind of demonstration of the veins. Anterior cerebral vein joined with the thalamostrate vein, which takes the anterior, middle, and posterior caudate veins, joined by the superior choroidal vein to form the internal cerebral vein, giving the posterior septal, giving the atrial veins. So these two will be joined with the vein of Rosenthal to form the vein of Galen. If you want to operate upon the pineal, you will be operating here. And this anatomy is very crucial. It is not a place for mediocre surgeons or for novices at all. Again, this is the venogram showing you the details that I've mentioned: anterior septal, thalamostriate, internal cerebral vein, into vein of Galen, and then into the straight sinus. So many anomalies, or let's say normal variations of how this vein of Rosenthal joined the vein of Galen and the straight sinus. You have to be familiar with these changes, and you have to make sure that you see them on the venogram, otherwise you would damage them. The point I want to make: stop reading from handbooks. It really breaks my heart to know that lots of neurosurgeons and lots of neurosurgical residents, they read from small handbooks, which just teach them to be parrots, saying what are the branches of so-and-so, 1, 2, 3, what are the branches of so-and-so, 1, 2, 3, without actually knowing the structures. So one has to read from textbook. And for me, I choose to read from Yazarjil since I was resident, and I still am reading Yazarjil. It's a beautiful book, and it's made of 6 volumes, volume 1, 2, 3A, 3B, 4A, and 4B. It's not enough. Maybe you need to read from another textbook, whatever it is, Sweet or Schmidt or whatever. I had to, and every resident and neurosurgeon must read Rotten operative book to learn the anatomy. You have to read Russell and Rubinstein pathology. You have to read the Osborne brain images and the neurological differential diagnosis of John Patton. Don't read from handbooks. I have nothing to do against Mark Greenberg. He wrote this as a note that he used to take in preparation for the exam, and then he thought of putting them into book. But I'm sure he would not be happy to know that residents and their mentors, they just take it as a textbook. This is handbook. Handbook means that something that when you buy a TV or a car, you have handbook for how to operate the car or TV. This is handbook. You put it in your pocket in your white lab. This is not a textbook. Greenberg is not a textbook. In addition to all the readings, you have to read the new developments from journals. For myself, I read these journals every month. I've been doing this for so many years, and I became advisor and on the editorial board of these beautiful journals. So, having done the anatomy of the pineal tumors, let's speak of the pineal anatomy. Let's speak about the pineal tumors. They are rare, 0.5, maximum 0.5 in adults, more in children, so it's more children pathology. And as I said, in the children, it's more malignant than benign. The kind of tumors that we'd expect in the pineal locus is either that the tumors are arising from the pineal gland itself, the material itself, or structures that surround the pineal gland would actually give you the tumor, or it is metastasis. So let's look at that. So If it is arising from the pineal gland itself, we have 4 groups: the germ cell tumor, the pineal parenchymal tumors, the glial tumors, and miscellaneous. Germ cell tumor constitute the majority, 50 to 70%. Excuse me. So the commonest tumor, if it is arising from the pineal gland itself, is germ cell tumor, followed by parenchymal tumors, followed by the others. Let's go through these. Germinoma is the commonest, and we have 2 types of tumors. We call them germ cell tumor, either germinoma or non-germinoma. So we speak about germinoma, germ cell tumor, or non-germinoma cell tumor. And these are the majority, 60 to 70%. And these include the germinoma, the teratoma with its different types, yolk sac tumor, perineal carcinoma, and choriocarcinoma. Germinomas. They respond well to chemo and radiotherapy, so much so that if you are sure that you are diagnosing germinoma, you do not need to take a biopsy, you do not need to do surgery, you just treat with radiotherapy plus minus chemotherapy. So that's the value of knowing these tumors. So this is kind of tumors that you would see. Germinomas in general, they love to go into the supracellular area and into the pineal locus. Again here, different germinoma tumors. And here the markers are important. If the alpha fetoprotein and beta HCG, human chorionic gonadotropin, are positive, then you can rest assured whether in the blood and CSF, better by both, finding positive in the blood and finding positive in CSF. But sometimes CSF sample is difficult to get, especially if you have increased intracranial pressure, you are afraid of herniation. So blood markers, alpha fetoproteins and beta HCG are positive, then no surgery, you go for radio chemotherapy only. The non-germinomatous germ cell tumor, as I said, that's the differentiate between the germinoma and non-germinoma. So we described the germinoma. What about the teratoma? Teratoma could be like this tumor here. It can be a mature cystic teratoma, or it could be an immature teratoma. Again, we described the germinoma, we described the teratoma. What about the other tumors? Embryonal carcinoma, choriocarcinoma. And again here, something that I will allude to because this really irritates me a lot. When people presenting with a tumor causing hydrocephalus, the thing that they do is to do a shunt, which is to me is a criminology at its best. It is just denoting that this particular surgeon has no idea about neurosurgery. He is ill-trained and he is training ill-fated residents. This is choriocarcinoma. And the second group, as we said, which is the second commonest, so germinoma, non-germinoma, germinoma, and teratoma and the others, the commonest, 70%, 60%. The second group is the tumors that are arising from the glandular tissue itself, the so-called pineal parenchymal tumors. And these are simply 3 types: pineocytoma grade 1, intermediate grade 2, and pineoblastoma grade 3. The commonest is the pineocytoma grade 1. So this is pineocytoma. It is the least aggressive, and it happens in the young adults. Pictures of MRI of pineocytoma. This is the intermediate type, aggressive but less than pineoblastoma. These are some of the pictures, and actually this is one of my cases. And the third type, which is the pineoblastoma, which is very malignant, and unfortunately it happens more in children. So the germinoma group, commonest, and the second group is the parenchymal tumors, pineocytoma, pineoblastoma, and the intermediate. Some of the features of the MRI of pineoblastoma. And as I said here, you use the markers in the blood and in the CSF to differentiate different types of tumors. So alpha fetoprotein, human chorionic gonadotropin, placental alkaline phosphatase, and melatonin is different secretion and different pathologies. So these tumor markers are good for diagnosis and they are good for follow-up of the treatment. Recently, this type of a tumor has been described and added to the parenchymal tumor, analytic primary parenchymal tumor. It's recently mentioned by the WHO classification, in the WHO classification. So some of the papers mentioned about this in new type of the tumors in the category of parenchymal tumors and the pineal gland. The third group are the tumors of the structures that are around the pineal, glial cells or ependyma or choroid plexus, etc., etc. Examples, these are only 10% of the tumors. So they can come from glial tumor, from the ependymal lining, from arachnoid cells, and from vascular cells. Pineal astrocytoma, glial, from the surrounding area, from the commissure in particular. And astrocytoma from the commissure, pineal astrocytoma, one of my patients with her histology. And here is the oligodendroglioma. Again, this patient has been referred to me with this. And I call this disease of the Arab world, a disease of the third world countries, where people only doing shunts simply because they are not good at neurosurgery, microscopy. So you see it in craniopharyngioma, in pinealoma, in third ventricular tumors, and the fourth ventricular tumors. The first thing that they teach, first thing that the resident do is to do a shunt. Shunt is a good surgery, but it should be done very, 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 and I keep saying very rarely, not for every case, simply because the surgeon is incompetent to do the surgery. Glioblastoma in the pineal region, ependymoma, and one type of the ependymoma is the papillary type of the ependymal cells. Meningioma arising in the pineal locus area, dermoids, epidermoids. One of my patients, 36-year-old female, and this patient, again, one patient of mine with this epidermoid in the pineal region. And this is before and after surgery. Again, lymphoma can be there, and this is one paper describing from New York, describing this pineal gland lymphoma. Lymphoma actually should go into differential diagnosis of most of the intracranial pathologies. Lymphoma, and this is one patient of mine coming from Kurdistan, Iraq, where the tumor is there in the pineal region. The last group, before we get into the metastasis, is the non-neoplastic tumor-like condition, something not related like arachnoids, cystosarcosis, AVM, cavernomas, aneurysm, etc. So this is arachnoid cyst, again in one of my patients. Pineal cyst. Pineal cyst we will discuss later. Pineal cavernoma in the region of the pineal vein of Galen malformation. And the last type is the metastasis, which is very, very rare. So this is the MRIs of a metastasis from bladder carcinoma. So we know now the anatomy of the pineal. We know now what are the tumors that can arise from the pineal gland itself. We are talking about germinomas, talking about the substance itself, parenchymal. We're talking about the surrounding structures like meningiomas and others, and we're talking about cysts and cystosarcosis and cavernomas and metastases. You have to add to them these differential diagnoses. These lesions can happen in the posterior part of the midbrain infarct, hypertensive bleed, Paget disease, lupus, vasculitis, Wernicke encephalopathy, Korsakoff syndrome, osmotic demyelination, very common in children. And now we come to the presentation. How do these pineal tumors present? Mostly by raised intracranial pressure, i.e. hydrocephalus. So do not please put shunts. Eye signs is very important, 80%. cerebellar signs, pyramidal signs, endocrine signs, etc. But the above two, the raised intracranial pressure and the eye signs are the commonest. When we speak about eye signs, we speak about Perinaud syndrome, and this is Henry Perinaud, a French man who discovered this and called it after his name. What is Perinaud syndrome? The causes are midbrain compression at the level of the superior colliculus. This can be caused by pineal tumors, but also can be done and caused by any lesion in the midbrain, tumors, vascular lesions, multiple sclerosis, infarcts, etc. So this is just a cut of the midbrain. This is the cross cerebri, and this is the internuclear cistern, and this is the back, the superior colliculus, and this is Edinger-Westrel nucleus, this is red nucleus, this is the third nerve nucleus, and this is the third nerve going this way. So any lesion in this area would cause Perinaud syndrome. Sometimes it's called dorsal midbrain syndrome or pretectal syndrome. And that is composed of conjugate upward pulses. They cannot look up. And this actually explains the sunset appearance we see in hydrocephalus in babies. The same principle. Convergence nystagmus, poor light reflex because you are affecting the third nerve and Edinger-Westrel nucleus, weak accommodation reflex, sunset appearance, which I described, and lid retraction. Let's see this video just to remind ourselves about the Perinaud syndrome. So when asked asking this girl to look up, she can't. No upward loss, palsy of upward gaze. And look at the nystagmus. Okay. See the other one? Same thing. Saccadic movement in nystagmus.
The video is not showing.
Oh, the video is not showing. Okay. What about now? Is the video showing?
Yes.
Yeah,
Yeah,
it's showing.
Okay.
Yes, yes.
So again, you can see the saccadic movements, and when this patient is asked to look up, there is palsy of upward gaze. So pulse of upward gaze, weak direct light reflex, weak accommodation, and this is Perinaud syndrome. Okay. So we'll come to the treatment. I have put to you the algorithm of the treatment that is accepted by everybody dealing with these tumors. For the initial diagnostic evaluation, you have to do brain MRI, spine MRI to know whether you have droplet metastasis or not. And then you do your tumor markers, alpha-fetoprotein, mainly beta-HCG, the others, if you have them, alkaline phosphatase and melatonin. Then once you do that, you have the MRI, then you have hydrocephalus or you don't. If you have hydrocephalus, there are so many options here. But the option that everybody goes to is to put a shunt. This is not on. This is really not on, unless you are living in the desert, in a place where there is no medical facilities. You can always do a third ventriculostomy. You can always put external drain. You can always do anything, but don't put permanent shunt, especially for a child. This is disastrous. And then you do the tumor markers, the alpha-fetoprotein and beta-HCG. Are they positive? This confirms the germinoma type. Just go for radiotherapy, chemotherapy, no surgery. If the markers are negative, then you have surgery to do, and according to the surgery, you behave and give the patient the adjuvant treatment accordingly. So true germinomas are radio chemosensitive and they have the best survival. So if you are in doubt and you have to take stereotactic biopsy, This is just to make sure that this is a pure germinoma. So this is a huge germinoma, and just with radiotherapy, it disappeared. So here is a good example of how to use radiotherapy, not the across the board treating anything and everything with radiation. This is not on. This is another crime that is being practiced every day around the world. Pineal parenchymal tumors, surgery, and followed by radiotherapy. They have the worst survival, as we said. Look at this. In the past, 1960s, that's what the people used to do. They used to put a shunt and send patient to radiotherapy. This is 2020. 60 years later, we are still doing what our ancestors have been doing. Stop putting shunts and send patients for radiotherapy, for goodness grace, please. So this is hydrocephalus of these patients. And I call this, and I insist, this is the Arab world disease. This is a third world country disease where everything and anything is treated with a shunt. And when you ask a resident, how many operations have you done? He would tell you, oh, I have done 300 surgeries. What are they? 299 shunt, revision of upper end of the shunt, revision of lower end of the shunt, treatment of meningitis, and so on and so forth. You would not, I would not accept to put a shunt in the head of my boy or girl. Please don't put shunts. Not only this, but the shunts are even done in the wrong fashion. I mean, even these people, they are not trained of the direction and where to put the shunt. The shunt should be directed into the trigone, into the occipital horn, the trigone. This is the largest area of the ventricle, and it should not go anterior so that you will not go through motor area. It should not go to the posterior occipital horn or this transverse or this. So these are not only that it is not indicated, but it is badly done because these people, these residents have been taught badly by bad mentors. So when you have CSF problem, you can also do the external drain, the ventriculostomy. The shunt, in addition to all what I mentioned, make your surgery difficult. If you are going through the endoscopy or you are going through the ventricle, you'll have difficulty. Now you want to do surgery, as I said, you have to approach different approaches for the pineal gland, but mainly you can classify them into above the tent or below the tent. So this is the picture. This is the straight sinus, the straight sinus, the transverse sinus, the sigmoid sinus. So you can go above, this is supratentorial, or go below infratentorial. You go in the midline or paramidline or far lateral. So it all depends on the tumor, the size of the tumor, and is it above or below the tent. And you have to know the anatomy, as I said, of the venous system. You should know them by heart, not from Greenberg, that the internal cerebral vein drain the following veins. This is not good. So here is the supracerebellar going to the tumor. And this is here, infratentorial, supracerebellar, or supratentorial. One kind of thing is this kind of approach, the supratentorial approach, where you retract the occipital lobe. So here you are on the right side, temporal. And luckily here we don't have much of draining veins, so you can retract easily, but you have to be careful about the visual area 17, 18, 19. So this is the tent, this is the straight sinus. You can actually cut the tent this way, about 1 centimeter parallel to the straight sinus. Here you are. You want to reach to the pineal, but also you want to see the anatomy here. So that's the anatomy is being hidden, and this is the tent, this is the straight sinus. So you open the straight sinus like this, the tentorium like this. Here's the scissor cutting this way. And then you have the whole area in front of you. You can see all the drainage veins there, and then reach to the pineal gland. Here you can see it here, lower down into the velum, superior medullary velum. And you can see both branches of the posterior occipital artery and superior cerebellar artery. So this is the approach, the supratentorial approach by splitting of the tentorium. You can see the internal cerebral veins, and then they're joined by vein of Rosenthal and the internal occipital vein. The other approach is the retrosigmoid, and I do this in the sitting position using the monitoring of the cranial nerves and the navigation if necessary, emphasizing that the navigator is your brain, not the machine. The machine is just to give assurance to you, it's just to teach your residents. But if you differ with the findings with the navigation machine, kick it with your foot and just continue with the navigation of your brain. So semi-sitting position that we have been doing for decades. Of course, you can do it with the park bench position. I've tried it. I like the sitting position. And as I said, it has so many advantages that you can actually operate easily. You don't need assistant. The blood and CSF will just flow by gravity. So once you open the craniotomy, this is what you see. And you have to be careful about these draining veins here. They are important. You don't cut them. You just make sure that you find the space between the draining veins to go. This is the tentorial surface of the cerebellum. This is the squamous or occipital surface of the cerebellum. And here is the petrous surface. So this is the kind of thing that you may face. So don't go and cut these. You go either in this window here or this window here. Of course, going in the midline is easier because you will go directly to the pineal gland. But with this arrangement, you have to go to one side. So all these veins draining into the tentorial sinuses are important. And here we are seeing the inferior vermian vein. So you look at the arrangements of the veins and then you decide. If you can go in the midline, go in the midline. If you can't, you have to go laterally. Usually it's, you'll find a window there. So little by little, you go and you see the draining veins, preserving them. Venous system is as important as the arterial system, but unfortunately, this has not been taught to our residents because their mentors are not good at it. If they are good at teaching, they should have taught them all about the venous drainage. So when you come to the pineal region, this is the arrangement. You are actually below. Here is the vein of Galen, and you can see the basilar vein of Rosenthal. These are the internal cerebral veins, and this is the superior vermian vein. So this is the pineal. And this area is covered with very thick arachnoid membranes. The thickest arachnoid in your body is there, unfortunately. Again, this is the arrangement that you are going to see. You have to be familiar with the anatomy. You will not damage any vein because every vein counts. Knowing the anatomy makes your life easier. It makes your patient's life easier. You can actually use both the supratentorial and infratentorial combined if there is a good need for that. The one person I know who has done the largest number of pineal tumors is Alexander Konovalov from Porodенko Institute in Moscow, Russia. And this period of time, 76 to 99, he operated in 287 patients. I met with him recently. His number now goes up to about 600 patients. Alexander Konovalov from Moscow. Of course, you can use endoscopy by just doing the usual endoscopy. You go through foramen of Monro and then redirect yourself to the posterior part of the third ventricle. These are the beautiful pictures of endoscopy from cadavers. I repeat and always say that endoscopy carries the future of neurosurgery. Look at this beautiful picture showing you this adhesion. This is vein of Galen, but it is covered with thickest membrane you can ever lay your eyes on. It's very thick and you have to do it with scissors or knife. It's not enough to just bluntly dissect. It has to be sharp dissection. And with sharp dissection, if you don't know the anatomy, you will cause damage to vein of Galen and death on table. What about radiotherapy? You can, as I said, it's a good tool. You give whole brain radiation, you give a tumor boost radiation, you give the neuroaxis radiation. For me, it should be administered to all patients with pineal region tumors, except cysts, meningiomas, epidermoids. As I always keep saying that we have acquired the gamma knife back in 1996. So when I speak about gamma knife, about radiation, I'm in a position of power, in a position of knowledge. And when I criticize it not because it's a bad machine, it's because of the bad people who are using the gamma knife. They're using it for anything and everything simply because they are not good neurosurgeons. So this is radiotherapy that we advocate for most of the patients with pineal tumors if the need is there. Chemotherapy also is useful adjuvant cisplatin for germ cell tumor. What about survival? Pure germinomas have the best survival. 5 years, 95%. 10 years, 88%. Look at the malignant germinomas, 20% 5 years and 0% at 10 years. Now to my series between 85 and 2017, I had 61 patients. I was lucky really to have this large number of patients, but I could only maintain follow-up of 48 patients, and these are the ones I'm presenting. Male to female was 3:1. The MRI pictures of my patients, you can see them, and most of the time the lesions are giant. As in this part of the world with the lack of health knowledge, people would just wait and wait and wait until things get really to a giant size like this. They are challenging, but they are interesting. So this is the MRI of these patients that I mentioned to you. CT scan, you can see that calcification in the pineal, the normal physiological calcification in the pineal, and sometimes you'll find calcification in a tumor. So you have to differentiate between normal calcification and abnormal calcification. So this is normal pineal gland with calcification, and this is abnormal calcification. Vessels, look at the vessels in the MRI, you can see the relationship of the tumor with the vessels. Look at here, you can see the internal cerebral vein on the upper surface of the tumor. You can see it here, deviated. You can see it here, the same, deviated. So you look at these tumors and the relationship with the vessels, and you would learn how to do your surgery. Look at here how the vein of Galen and the internal cerebral veins are pushed. Here they are inside the tumor, and so on and so forth. And I'm showing you these MRIs, and these are my patients. MRA, MRV are very, very valuable. You have to know exactly what you are dealing with and where every vein is in relation to the tumor. Coming to the pineal cysts, this is usually some patients are referred to me for surgery. You don't need to operate on pineal cyst unless necessary, and I will tell you how. This is the normal pineal size, and this is the pineal cyst. Some of the cysts that I receive as pineal tumors, but you don't need to really operate upon them. This particular one is from Ann Osborne book, which I keep going back and read from. So pineal cysts. You can get pineal apoplexy, bleeding into the pineal cyst. This is a very beautiful paper by Serene in the Neurosurgery 2016. 232 patients, 56% had cysts. Imagine, half of these patients had cysts, but they are normal. You can have single cyst, you can have multi-cyst, you can have many more cyst changes. If you follow them up, and I advocate that you follow them up for all the cysts, you will find that 50% will be stable, only 40% will increase, 10% will decrease. And for the increase in size, you have the option of whether to operate or not. This is again from Ann Osborne, whether the calcification is on the side or it is surrounding the lesion, to differentiate between the pineocytoma or a pineal cyst. So pineocytoma is a cyst with the rim of calcification. Some of the illustrative cases of mine, this 27-year-old female patient with epidermoid tumor in the region of the pineal, and I call them tumors, not cysts, because the whole world, all the neurosurgeons, all the pathologists stop using the term cyst. The epidermoids are not cysts, they are tumors. Go back to original paper by Yazarjil back in 83 or 84. And here you can see that this is an epidermoid. And this is after surgery. No shunts, no misery of shunts. There's no need for. And this is the immunohistochemistry that we used in these patients. Other patients with an extensive 43-year-old male patient with extensive epidermoid in the region of the pineal before surgery and after surgery in the lower row, and the patient doing well. And this is his follow-up. Another one, male patient, 41-year-old, much more extensive epidermoid, pre and post-op. And to me, the only time that you can see a pineal is when you operate on such cases of epidermoid tumors, because the pineal gland is still intact. It's not destroyed by the tumor. In most of the cases, you don't see a pineal gland, you see a tumor that you remove. But here, if you take the epidermoid, you will see the normal anatomy of the pineal gland with its two coronae, two crosses, one cross on one side and the other on the other side. Arachnoid cyst, and this 73-year-old female Jordanian patient. Again, she presented with hydrocephalus. So the easiest thing is to put a shunt. Crime against humanity. And this is after excision, drainage of the cyst, and here in the lower row showing the follow-up. This young patient, a 19-year-old with this tumor in the region of the pineal, it turns out to be a pilocytic astrocytoma. And this is her post-operative pictures. And this patient from Bahrain with this lipoma sitting on the tectal plate, quadrigeminal system, quadrigeminal plates, and you can see that he's tilting his head because of the fourth nerve palsy. And these are some of the still pictures. This is infratentorial supracerebellar, and you can see here, you can see the veins and the tumor and the lipoma to be dissected. This is the fourth nerve coming from the back of the midbrain, and this is the tumor here. Now have liberated the fourth nerve patient as well, and his upward gaze is improved. And this patient also Jordanian, 37, with this meningioma of the pineal locus. This is before surgery. This is after surgery and follow-up. The last case that we are reporting here with a video, so that we'll conclude with that, and I will give the stage to my daughter, Dr. Asil Sbeh.
Hello everyone from beautiful Amman. I'm Asil Sbeh. I'm a neurosurgical trainee at the Royal Medical Services here in Amman, Jordan, and I will be presenting today's case. Our patient is a 37-year-old male patient. He came from Bahrain, and he had a significant history of 3-month duration of headache, decreased visual acuity, and diplopia. It's worth mentioning that decreased visual acuity is a broad and vague complaint, and it should be thoroughly investigated to see what the patient is actually describing. He also complained of amnesia and urinary incontinence, in addition to right upper limb weakness. His vital signs on examination were okay. Chest, heart, and abdomen were fine. Glasgow Coma Scale 15 out of 15, although he had a speech impediment and he was dysarthric. And this could be actually explained by increased intracranial pressure. He also had a third and fourth cranial nerve partial palsy, which we will see. And as I said, he had urinary incontinence of urge component, and there's many types of incontinence that should be investigated also thoroughly, as each one would indicate the location of the problem. He had impaired upward gaze, which is expected in a pineal gland tumor, and he had decreased visual acuity, and he had the famous retractorious nystagmus, in which is seen in the pineal gland tumors. And this kind of nystagmus is actually described by a slow component while abducting the eyes and a fast component on adduction. Cerebellar signs were intact, but he had an ataxic gait, which can be explained by the hydrocephalus. He had right upper limb weakness, as we said, he had a 4+ out of 5 with no hyperreflexia, but he had hyperreflexia bilaterally in his lower limbs. ECG and chest X-ray were okay. He had normal preoperative lab investigations, except for mildly elevated liver function tests were okay and didn't need any further investigations. Pre-op imaging, this is the MRI T1 without contrast. We can appreciate the very apparent hydrocephalus, dilated third ventricles, and third ventricle and the lateral ventricles, and this is our lesion right here. This is with contrast. We can see heterogeneous enhancement, especially here in the center. More cuts denoting the impressive hydrocephalus, and here we can see the temporal horns of the lateral ventricles, which we don't normally see. And the lesion is actually compressing the aqueduct, which is encouraging more hydrocephalus. More images showing our lesion and the hydrocephalus, and as we said, MRA and MRV is a basic investigation when it comes to our patients. The MRV is particularly important to appreciate the internal cerebral veins and the relationship of the tumor with the vein of Galen. The MRA was normal except for the bowing of the anterior cerebral arteries, which is seen in hydrocephalus. More cuts so we can appreciate the tumor, and here we can see the tumor resting on the tectal plate and actually flattening it. Beta HCG and alpha-fetoprotein were sent, and they were normal. Consultations, we usually consult our psychiatry for KPS, Karnofsky Performance Scale, as it can assess in the prognosis of the patient and actually can decide if we can go further on with the surgery or not. The ophthalmology, obviously, for the visual acuity and the nystagmus, and they confirm the impaired lateral and upward gaze palsy. There's the visual field for the patient. You can see non-specific decreased visual acuity in the right and left eyes. Respiratory team was consulted for lung function test. It was okay. And the urology for the urinary incontinence, for which they ordered analysis culture and ultrasound, which were okay. And finally, the anesthesia consultation, which denoted the patient to have an ASA grade 3 due to increased intracranial pressure. And it's worth mentioning that the ASA ranges from grade 1 to 6, and 3 is a bit of a risky surgery. This is our consent form, our usual consent form. And here we actually mentioned that the patient may need later on BP shunt for hydrocephalus if that was not naturally treated with the removal of the tumor. Thank you.
Okay, now we'll go for the surgery itself, looking at the video. Remember, the patient is in the sitting position, and here is the opening. You don't take the dural opening down so that it will keep the cerebellum.
Excuse me, Dr. Sabea, we're not seeing the video.
Okay, we'll do the trick here.
Okay. There we go. Okay.
Okay. As I said, in sitting position, so this is the right side, this is the left side. And as in most of the cases, you find amalgamation of the drainage veins going into the tentorial sinuses. But here, you're finding the arachnoid and trying to find the opening. I found an opening here. So I don't need to go in the midline. I go in this window or that window, and then I go sort of this way into the pineal region. I'll just proceed with that and going further. This is the supracerebellar infratentorial approach. And here you can have a glimpse of the very thickened arachnoid in this area. Of course, the easiest thing would be to cut these veins out, and then you'll have a huge cerebellar infarction. But this is difficult, but you can manage. So here we are, and you can look at the very thickened arachnoid, which will not go easily. It has to be cut sharply with the scissor or with the knife. But here you are looking at the vein of Galen, which is on top, and you are looking at the precentral vein, and you are looking at the mesencephalic, lateral mesencephalic vein, vein of Rosenthal, etc. So you know your anatomy, you know where to open, and then you proceed. And once you do the first opening, then it would be easier. You can see this is very thick. I'm just showing and moving the instrument to show you that it is really very thick. So I'm using the scissor to open it, sharp dissection, and then I go laterally. It's easier. The adhesions, the thickened arachnoid is more centrally. So here again, you are trying. Now the surface of the tumor is exposed. I go around it. So vein of Galen is here, vein of Rosenthal, the midline precentral vein, and the others. So this is the tumor. You can see vein of Galen here. Now you cauterize the surface of the tumor, and same principles, debulk the tumor from inside, go around it, dissect its relationship with the other structures. Again, you can see the tumor, you can see vein of Galen. So once you debulk the tumor from inside, you can actually go around it, dissect it from surrounding structures. No rush here. Every structure there is important. Now you start to see the cavity of the third ventricle. As you are removing the tumor, the cavity is in front of you. Here you are dissecting this part of the tumor from the pulvinar here, and these are the branches of the superior cerebellar artery. In particular, this should be the medial posterior choroidal artery. So careful dissection, trying to find a good plane of cleavage. You're not interested in just biopsy and getting out. This is for mediocre surgeons. You are going for a kill. You are going for removal of every ion of the tumor. Now you can see the roof of the third ventricle in the depth, but you still have a tumor here and there. So you have to go and remove it. This is the roof of the third ventricle. This is foramen of Monro here, foramen of Monro here, and this is the roof with the two internal cerebral veins coming towards you. So sort of arching like this to come here. continue the dissection of the tumor. Now going to the other side, try to dissect the veins. This is the surface of the tumor. So tumor is hidden on the other side. But remember, you have gone from the right to the midline. So this is a kind of a blind angle for you. But you want to take the tumor, dissect it off these veins and bring it to your field. And that's what we are doing here. And we are removing the tumor with this is the vein. This is actually pineal vein, which is a branch from the superior vein coming from the vein of Galen. You can see the veins intact here, the midline. We are removing sheet of a tumor on the undersurface of vein of Galen. Still tumor to be removed. You're not interested in a biopsy, you're interested in a kill. So you try to move every piece of the tumor you can find and you can reach. This is almost the last piece. Again, here back into the cavity of the third ventricle, the roof. Remember, the patient is sitting with his head flexed, so you are looking at the roof of the ventricle from below. You wash and wash to make sure there is no bleeding. And then you just close. You can see the vein, Galen, the thickened arachnoid here. You can see it here very well, very clear. Okay. So we got CSF, of course, as we were in. We don't do CSF analysis of this huge tumor under hydrocephalus. It will cause herniation. So as we were during surgery, we had got CSF and there were no cells, no malignant cells in it. Histopathology was reported by our Dr. Hussam Farsakh, who's a fellow of the American College of Pathologists, and he showed this kind of tumor. This is a pineocytoma, medium grade or high grade. So it is not a benign pineocytoma. It's a grade 2 to 3, intermediate or malignant, with all the malignant changes in these cells. And the immunohistochemistry, the nistine, the NSE, the synaptophysin, and Ki-67 was 10%. So this is malignant tumor. So this is the report. Post-operative course, the patient was awake on table because he must be. If he is not, then there is a problem. We don't send them on ventilators at all. And the following day, the MRI is done, not CT scan, but MRI. Don't mislead your residents by doing CT scan post-operative. This is a trick which is really dirty, because if you want to hide something, you will do CT scan. If you want to show yourself and show your team and show the patient and the family that you have done your job well, do brain MRI. Don't send patient home or to their countries without MRI. So this is the immediate post-operative MRI showing you total excision of the tumor. Hydrocephalus is resolving on its own, and he was ambulated and so on. The psychological analysis, which was done before, showing Karnofsky performance scale of 60, after surgery, it turned out to be 90, which is almost normal. Normal is 100. So he was discharged, and this is the medical report that we send them with, the discharge summary and the recommendation. This is the patient, and we followed him. He went back to his country, Bahrain, and as he was there, he sent us his pictures. This is the spine MRI showing no metastasis. As he was receiving radiotherapy in Bahrain, he developed hydrocephalus, for which he received a shunt. I don't mind that. 6 months later, no tumor whatsoever, Patient is well. 9 months later, the same, no hydrocephalus. 2.5 years later, no tumor. 3 years later, no tumor whatsoever. 3.5 years later, same. 5 years later, also same, and he was doing really well. With this, I finish and I thank you.
Okay. Okay, Doctor, all set? Okay, very good. Now the floor is open for questions or comments. Part of the good thing about this platform, as Dr. Sabeh will tell you, is the interactivity. So please don't be afraid to use that aspect. Any comments or questions?
Yes, I have a question, please.
Go ahead.
Please.
Thank you, Dr. Sabeh, for this elaborative and this very clear presentation. You covered all the aspects of pineal tumors from the first scratch to professionalism. My question is about choosing the approach, whether to go supracerebellar intratentorial or suboccipital transtentorial. Is it just the veins that would, the relationship of the tumor to the veins that would decide which approach to choose, or there are other criteria that should be taken into consideration while making the decision for the choice of approach?
Sure.
Another question,
yes.
My second question is about the timing for the CSF diversion techniques. How long should we wait post-operatively to decide that this patient would need a CSF diversion? And then we do an ETV or we put in ventricular peritoneal shunt. Thank you.
So the first question is, what is the approach? Should we go supratentorial or infratentorial? And if we go infratentorial, should we go infratentorial supracerebellar in the midline or intermediate or far lateral? If you read the book of vascular surgeons using this technique for the cavernomas of the brainstem, then you will know that the direction of the lesion would direct the surgeon for the approach. So basically what I look at the tentorium, I look at the straight sinus, how much of the tumor is actually below that level or above that level. And I go, if 2/3 are below the tent and 1/3 is above, I will go definitely infratentorial. If it is the opposite, 2/3 above, 1/3 below, I would go supratentorial. But of course, the size of the tumor, the direction of the veins, relationship with the veins, if it is pushed anterior or lateral or whatever, so this all goes into consideration. So mainly look at the level where the tumor is in relation to the tent, above or below, and the relationship with the veins. You may need to do it in 2 stages. You may need to do the stages for the supratentorial and infratentorial at the same time. So multitudes of approaches that you can use. As for the CSF diversion, I never ever put a shunt at all for any patients before I take the tumor out. As I said, this is a criminology, and I have seen in my lifetime so many crimes being carried out, and they are still being carried out in this part of the world. Simply, the surgeons are not well trained, they are training ill-trained residents, and this is the surgery that they know to do is to put a shunt. But you and I would not accept to put a shunt to our beloved children. I'm against putting a shunt. I believe the best shunt is no shunt. Shunt is an era of the past. It has stopped. Umayya Reservoir is an era of the past. It stopped. Let's go into the future, not to live in the 1960s in the infancy of a neurosurgery. Now, if I have a patient with hydrocephalus and the tumor, I would go in immediately as soon as the conditions would permit. I would do brain MRI, spine MRI, and the tumor markers. And I would plan the surgery so that I would relieve the patient of his tumor and with his hydrocephalus. Now, with the follow-up of the patient, clinically and radiologically, he would decide whether he needs a shunt. This patient, the last patient we mentioned, he went back to his country to receive radiotherapy. And as he was receiving radiotherapy, it seemed there was edema of the aqueduct of Sylvius, and he developed hydrocephalus, for which he received a shunt. So the algorithm is very clear to me.
Okay, very good. More questions, comments?
Thank you.
Thank you.
Hello, good evening.
Go ahead.
Good evening, Dr. صباح. مساء الخير للجميع. Good evening, sir.
Hello.
I just want to ask about this dose radiotherapy. I know most of neurosurgeons no more using it, but it's written in big books such as humans. What's your opinion about it?
The dose of the radiation, so you have two types of radiation. Radiation, if it is malignant, radiation for the whole brain, and then booster dose to the tumor itself. Usually the dose is 45 to 55 degrees. But as I said, the gamma knife is a very useful tool. It was maintained by Lars Laxell of Stockholm. And if you go back to his old teaching, 1968, he would tell you gamma knife is for a very deep-seated lesion that cannot be reached by surgery, or the patient is unfit to have surgery. It cannot be that this doctrine of gamma knife be changed into anything and everything is treated with radiation. This is not on. This is not medicine. This is not surgery. This is criminology at its best. Gamma knife is a useful tool, but it should be used not indiscriminately like it is being used now. So radiation is a good, valuable adjuvant treatment for surgery, but it has to be used wisely.
Excuse me, sir. I'm just asking about using radiotherapy as a diagnostic tool.
No,
what we call this dose radiotherapy.
Yeah, I'm against that because you are taking so much risks. But the risk that you are taking is on the expense of the patient, not in your expense. I'm against taking risks on the expense of the patients. If you do the MRI, if you do the spinal MRI, if you do the tumor markers, the road is very clear. And if you are in doubt to give radiation and then do surgery, this is bad because if you have done any surgery after radiation, you would know what I'm talking about. It's hell. It's hell to operate in a radiated area. So I'm against it.
Thank you, sir.
Okay, thank you. Next question, comment? Go ahead,
Hello.
Rafiq. Go ahead, Rafiq. Welcome.
Hello. Hello, John. Hello, Dr. Sobeh.
Hello.
I'm Dr. Rafiq. I'm from Algeria. I'm a young neurosurgeon.
Hello, nice to meet you.
Thank you for a very nice and very clear presentation. So I have one question for you, please. For the sitting position, what are your tips and tricks for preventing complication of sitting position?
Sure. The main complication of sitting position that everybody fears is air embolism. Air embolism is the main fear. I always remind residents and the surgeons that air embolism can happen in the supine, in the prone position, in any position of the surgery. It can happen from just incising the skin. So you have to be prepared for that, especially in the sitting position. Keeping the feet at the level of the heart is a good safeguard. As you are opening, you secure hemostasis at every step, skin, subcutaneous tissue, muscle, etc. And if you reach the bone, you take the bone out, cranectomy or craniotomy, and then you wax. You take the tumor bone and you wax. So every step on the way, you ask the anesthetist to give you Valsalva or to squeeze the jugulars to see if there is any hidden bleeding that you have not seen. In the sitting position, you may have a good bleed, but you don't see it because it's sucking the air in. Now, once it happens, and to me, there is air embolism in every single case that you put in a sitting position. If it happens, then it is the interaction between the surgeon and the anesthetist. And what you do is to stop the surgery, put saline, and then put the patient back, control the bleeding, and then continue the surgery again. So with an experienced anesthetist, an experienced surgeon working together, it's very easy to control any air embolism. I tell you this, I have hundreds and hundreds of sitting positions for various pathologies. I only lost one patient, and that was very early in my career. Since the 85, this was the patient I lost for air embolism. I did not lose any single patient.
Okay.
Thank you, sir.
Pleasure.
Okay, we have a couple of written questions. Unless someone, does
Can
someone
I
have
ask a question?
Yes, of course. Go ahead.
Hello.
Yes, go ahead. Go ahead.
This is Dr. Altaf Ali from Pakistan, Karachi.
Hello.
I think it was a very good talk. Professor Ibrahim, it was really nice to hear you. and the way you described each and everything with anatomical three-dimensional description was really splendid. Thank you very much, sir. So
Thank
my
you. And,
question is related.
Yeah, please.
Yeah. So my question is related to use of new techniques, new technology rather, like neuronavigation. Do
Yes.
you use neuronavigation in these cases?
Yeah. Actually, I mentioned it through the lecture that we have a navigation machine in the room where we are operating. I use it if necessary, but I always maintain this. And I tell this to my residents. Where would you open without the navigation? And then put the navigation and see where you open. Where is the lesion during surgery? Where do you expect it? And then put the navigation. For me, navigation is a teaching tool. It is not to guide any good neurosurgeon through his way through his surgery. And listen to Yazarjeel all through his life. He's now more than 90, 95 years old. He kept saying, your navigation is your anatomical knowledge, not the navigation machine. So it's a good tool. It's a good teaching tool for the residents. But at the end of the day, if I say that the sixth nerve is here and put the navigation says it is there, I just throw the navigation away and continue with my own visual assessment and visual knowledge of the anatomy of that area.
Okay. Very
And
good.
if you are from Pakistan, say hello to my friend Rashid Juma. We trained together in Atkinson Morley Hospital in London. He's my close friend.
Oh, great.
Yeah, so nice to know that because he is my mentor. I have been trained with him,
Yeah,
and
he's a
I
great-
still work with him. My hospital is same. I'm working with him as a co-neurosurgeon, but I was trained with him.
Super.
I will
We work-
definitely convey your message.
Sure. Thank you very much.
Good evening, sir. Can I ask a question?
Yes, of
Yeah,
course. Go ahead.
Myself, Rajesh, sir. I'm from India, resident. Sir, my question, first of all, it was a very good presentation, sir. I have been following your presentations recently, sir,
Thank you.
due to this lockdown. Sir, my question is, how do you differentiate radiologically the epidermoid cyst and arachnoid cyst of the pineal regions?
Yeah, it's very easy by doing the diffusion. Diffusion technique can tell you this. A white tumor when the CSF is black is an epidermoid. A black lesion when the CSF is black is arachnoid cyst. So diffusion technique would tell you this.
Okay, sir.
Having said that, through all my career, I operated only in one case where I thought it was an epidermoid, and it turned out to be arachnoid cyst.
Okay, sir. What is your opinion on fenestration if it is an arachnoid cyst, sir?
You have to have a good wide excentration. You have to take a big part of the capsule. So for arachnoid, to me, the main treatment is not fenestration. The main treatment is to communicate this cyst with the CSF pathways, whether this is in the Sylvian fissure to the cisterns around the optic chiasm or around the carotid, or into the cistern around the in the area of the cistern of Galen or mesencephalic cistern. In addition, you take part of the capsule as a definite proof of your diagnosis that this is an arachnoid cyst. But just to take a small piece and say I have done fenestration is not enough, because I have seen big holes closing by time, but it will not close if you communicate it with the CSF pathways.
Okay, sir. Thank you, sir. Thank you very much.
Thank you.
Okay, more comments, questions? I have a couple of text questions unless someone has a question ready orally. Does anybody have a comment question? The Dr. Zaldam asked, what is the site of entry for stereotactic biopsy of the pineal gland?
Again, it depends on the size and the direction of growth of the tumor, whether it is laterally, superiorly, or inferiorly. If it is going into the back of the third ventricle, then you can use the endoscope through the foramen of Monroe and direct yourself backwards. Then you can have a biopsy from there. Or if it is laterally, you can actually use the usual stereotactic approach through frontal horn approach and then take the biopsy out.
Okay, Dr. Zafdam asked another question. Can supracerebellar infratentorial approach be done or in the prone position?
Yeah, it's extremely difficult because in the prone position, whatever you do, you cannot get into the right angle there. You can, but it is with a great difficulty. And the most important difficulty here is that everything will be pooling in your area of operation. The pineal gland is in the depth of your operation. CSF and blood will be accumulating there. The angle is not right. Even if you do traction of the shoulders, even if you lie on top of the back of the patient and operate, it's really difficult. So I do not do that in the prone position. And in the past, I used to do park bench position, but again, sitting position gave me the clue for all these lesions.
Okay, someone asked, could you give me some tips on which books to read?
I mentioned some of them, but my point is that I've seen lots of residents graduating with the only knowledge they have is from Greenberg. I have nothing against Greenberg himself. This man was a resident. He used to summarize his reading, and at the end of the day, he put it into a book. It's good for the last reading, just the night of the exam. It is good to put it in your lab coat to refer to it to see some information. But it is teaching you what I call parrot, 1, 2, 3, 1, 2, 3, 1, 2, 3, without actually knowing. So if you ask a candidate who has read the Greenberg, what are the branches of the internal carotid artery? He would tell you immediately, without hesitation, the superior hypophyseal artery, the ophthalmic artery, posterior choroidal artery, anterior posterior communicating artery, anterior choroidal artery. He would tell you these branches, but he does not know where to find them and what is the value of them and how to see them on angiogram. Now, this is disastrous. You can only read this from textbooks. And I keep saying that you choose your textbook. I'm not pushing you to buy a certain textbook. Choose a textbook of your choice, but have a textbook, a large textbook. To me, I found Neurosurgery, since I was a resident, a very good textbook. So I kept reading it. I did not finish it. Till today, I did not finish Neurosurgery. I even go back the night of surgery that I'm doing the following day to read from. Keep a certain textbook. Neurosurgery is a good textbook of neurosurgery. Sweet, whatever, you can use your textbook. And the other thing is you have to have a book on radiology. I choose Anne Osborne. You have to have a book about pathology, neural pathology. I use the Rubinstein. You have to have anatomy book. I used Albert Roten. But this will teach you the basic anatomical, basic operative teaching. But you have to keep up with the updates. And the updates, you can only get them from reading journals. I read 7 journals, 10 journals every month. I don't read it from cover to cover. I choose the papers that I read, which is in my domain.
Okay, we have a question from Amy Nata. In short, she says, as I'm still in training, I additionally appreciate the advice and cautions on placing a shunt injudiciously. She's just made a remark.
Sure. I mean, as I said, shunt surgery occupies a major part of the training of residents in this part of the world. And I really feel sorry that a neurosurgeon would finish his years of training, 6 years, and the only surgery he can do is shunt and to evacuate burr holes for subdural hematoma and the disc disease, and consider himself as a neurosurgeon. He is not. We are graduating people who are not actually being well trained. We are giving them certificates, and sometimes we're giving them certificates not to practice properly, but to kill. So it's bad to give certificates for people to kill.
Okay, very good. Okay, Dr. Sabaya, I would like to thank you very much, and I'm sure all the panelists do. When is your next lecture?
So, okay, Monday. Next month.
Okay, okay, that'd be great. Okay, we look.
And we'll be speaking about supracellular meningiomas.
Okay, great. Okay, then we'll see you then. And thanks all the panelists for coming.
Thank you.